I'm Jocelyn, and I'm going to be doing my newborn assessment video. So the first thing I'm going to do is put on some gloves. So the most important thing for a newborn is the thermal regulation. So the first thing that I'm going to do when they hand me the baby is go ahead and put them on a blanket here, and we're going to dry them up from all that fluid that's on them, because they do come out of the mother's amniotic fluid. So we're going to dry them. And then we're going to pick them up and discard of the wet cloth and then blankets. And then while I'm here, I can take a good look at the skin color because they're crying. So nice and pink. I can go ahead and kind of feel to make sure that their temperature feels okay. I can look at their skin turgor, which is a little bit harder, but newborns have very like hydrated and moist skin, and the premature babies usually have thinner and more sticky skin, so I can look at all of that. Right here, when babies are first born, they do have a little bit of cyanosis on the extremities because they're trying to warm up their body, and the extremities are not the most important thing, so they're gonna center their body warmth. And then I'm also gonna look for jaundice, which is not normal in the first, because there's pathologic jaundice, which is not normal because that's usually seen in the first 24 hours, which they shouldn't have a huge yellow tint to them. But a couple of days after birth, it's normal to see a little bit of physical jaundice because their liver is not quite developed all the way yet, and they can be a little more yellow than they should. Okay, so then after that, the parents are gonna want to know what their baby weighs. So we'll pretend this is my scale. I put a blanket on it. I'm going to put it here, and I'm going to measure in ounces and pounds for the parents, but I'm also going to measure in kilograms. And then usually on the scales, they have the measurement here where I can kind of stretch out the baby's leg and kind of see from the head to the toe what they're like, or I can use a measurement of the head to the bottom and the bottom to the leg extended. So we'll get that out of the way. So after I measure the height of the baby and the length, I'm going to go ahead and do the measurement of the head circumference, which is right above the brow. So I would be measuring here. And after I measure the head, I'm going to go ahead and go to the chest, which is right above the buds of the breast. So I'm going to do it here. I would measure that. And then I would go to the most prominent part of the abdomen, the largest part, and I would go ahead and measure that as well and make sure that that's documented. And then after I finish measuring, I am going to go ahead and listen to the baby's heartbeat, which should be anywhere from 110 to 160. And then I'm going to go ahead and listen for an entire minute because they have very irregular heartbeats. So I'll listen here. And after I was to listen for a minute, I would go ahead and listen to the heart sounds of the baby while I'm here. So that's all 5 of the ones: the aortic, pulmonic, Erb's point, tricuspid, and mitral here. And then I'm going to go ahead and gently roll over and listen to the lung sounds in the back, which I might hear a little bit of fluid because they are in the amniotic fluid before this, and their lungs sometimes still have a little bit of it in there when they're first born. So I'll listen to that, and then while I have my stethoscope here, I'm gonna go ahead and listen to the bowel sounds here, starting from the lower right, which would be my left, but the baby's right. Go up into the 4 quadrants, ending in the lower left, which would be my right. Okay, so, while I was doing that, while I'm listening to the lung sounds, I can also go ahead and take a listen and a feel also for their breath sounds, which should be 30 to 60, because they do breathe a little bit fast. So I would make sure I get their respiratory rate too. Okay. So now that I've gotten all of that, I will go to the get the axillary temperature next, which this is my thermometer. We'll just pretend that it is. I would go ahead and get the axillary temp. Sometimes hospitals will get the rectal temperature, but that's only a one-time thing. We don't want to mess up anything in their tissue or in their rectum, and normally if they have a bowel movement, then we know that their rectum is pee. So I'll get the axillary temperature, and then while I'm here, I'm going to go ahead and assess for pain, which there's different scales of pain that I think probably some hospitals have for you to tell, but the biggest one that I know you can tell, that you start to learn, the nurses learn and the mothers learn, is the sound of the baby's cry. So you can kind of tell the difference in when maybe they're just hungry or just a little fussy, or when they're actually in pain and something is bothering them and there's something wrong. So after I look for their pain, I'm going to go ahead and flip this baby over so that I can look for lanugo, which is hair that is usually in the lower back area that'll fall off eventually. And while I'm here, I'll also look for the Mongolian spot, which is just a dark spot right above the buttocks that'll go away after a little while. But if there is a Mongolian spot, I would definitely document. And then while I'm here, I'm going to look for the symmetry of the buttocks, make sure that there's not one side lower than the other, because that would indicate maybe a hip dislocation or some type of problem there. And while I'm here, since I have the baby like this, I can look for the curvature of the spine, which is supposed to be in a C shape. So I would look for that there and make sure there's no spinal abnormalities or something that shouldn't be there that would indicate further problems. I would also look for the stork bite or any type of rash on the baby's face while I'm here too. So I can also document that along with the Mongolian spot if there is one. Next I'm going to move on to reflexes, which we will start with the moral reflex, which is the startle reflex. This one, there's a couple different ways to do it. You can snap your fingers, gently pick up the baby and drop them just a little bit, but I have experience with babies and nieces and nephews that usually they get scared by themselves just randomly, and they'll go and they'll get startled a little bit. And when that happens, we're gonna look for symmetry in the arms when they go up and they're startled, because if one is shorter than the other, or longer, that would indicate that maybe they have something wrong with their clavicle, or there's some type of shoulder displacement or anything like that. So I would also feel here for the clavicle, which is right along here, for any lumps, crepitus, crackles, popping, anything like that. So I would look for that there. And then while I'm here with the reflexes, so after the moral reflex and making sure that those are symmetrical, I'm going to look for the blink reflex. So if their eyes are not open, you can do just kind of, to get them to open, you can kind of put your hand above their eyes, or just kind of look at them like this. And when they do finally open their eyes and you know that they can blink, you're going to go ahead and take your pen light. I'm going to go ahead and take my pen light, and I'm going to look for their pupil dilation, constriction, kind of looking in there. newborn babies' eyes are swollen. They're usually hard to see, so after they're born, they get the erythromycin ointment in their eyes, so sometimes I might not be able to see as clearly. But I'll go ahead and look here, and while I'm here, I'm going to go ahead and look at the conjunctiva, the sclera, to make sure that there's nothing abnormal there. And then also, while I'm here in the eyes, I'm going to go ahead and look for the line that goes back to the top of the ears, which it should be right on center with each other, because if the ears are lower than the canthus of the eyes, and that could indicate Down syndrome or some other abnormality or congenital heart defects. So I went ahead and looked at that there. And then the next thing, while I'm just getting a couple things done while I'm doing reflexes, but the next thing I'm gonna do is the rooting reflex, which is I'm gonna rub my finger here, and normally the baby would go and turn their head towards it because their instinct is to look for their mother's breast. So while I'm here and they turn and I make sure they have that reflex, I could go ahead and stick my finger to check for the sucking reflex, and to also feel the soft and hard palate to make sure that everything's okay there. There's no maybe cleft lip abnormalities that might cause the sucking reflex to not be there, and to also just make sure that the mouth is okay, they can swallow and things like that. Next thing I'm going to do is the palmar reflex, which is which any baby does, which is if you just grab their little hands, their fingers will grasp in the palms of their hands, they will grasp your fingers. And they also do the same thing with their feet. When you put their toes will curl around, and you can just make sure that they're grasping with both their hands and their feet. And the next thing I'm going to do is the tonic reflex, which was described as like a fencing pose. So I'm going to go ahead and, when I turn the baby one way, like to the camera, the arm that is on the same side that they're turning would go out that way, and so would the leg, and it looks kind of like when you fence. And then if I was to turn it the other way, the other arm would do that, and the other leg would do that, and this one would curl here. So I'm gonna make sure the baby has that reflex. And then I did already check for the curvature of the spine, make sure that there's no abnormalities there. But I'm gonna go ahead and do it one more time. So we're gonna check the curvature of the spine here. And then babies do this thing where when you put them here, they're gonna do the prone crawl, which is they're gonna kind of scoot up here with their butt and go further. And then I also already looked at the buttock symmetry, which you can also see when you're doing this to make sure that they have that. The next thing I'm gonna do is kind of have a feel on their head. I'm gonna look for the anterior and posterior fontanelle, which the diamond shape is the anterior here, and then the triangle shape would be towards back here. I'm going to feel like their suture lines to make sure there's no hematomas or stuff like that, because things happen when the babies are born. If they're pressed up against something, they might come up with a spot that's kind of full of blood, like a bruise, or they just might come out like a little cone shaped if they come out a different way. That's when their suture lines are meant to go over each other and stuff like that, so that they can fully come out of the birthing canal. So you would just kind of make sure that they feel the occipital part of their head back here. There shouldn't be like any abnormalities, any super caving in or anything like that. The next thing I'm gonna do is go ahead and look at the baby's face. I'm gonna make sure everything is symmetrical, so their cheeks are symmetrical. You wanna make sure that they don't have any type of nerve damage, just in case they were born with the help of forceps or any type of vacuuming, suctioning thing. You just wanna make sure that their face is symmetrical, their ears are symmetrical, their eyes, looking at their nose and their mouth. And then babies also have something called milia bumps when they are born, which they're like little sebaceous gland pustules. They kind of look like you'd want to pop them, but you don't want to do that because the baby will absorb them and they'll go away on their own. And then, so after I observe that, I'm going to go ahead and look at the ears again. I'm going to want to bend them forward kind of to make sure that the cartilage goes back into place, that they have that outer cartilage. And kind of look at that on both ears. I also want to make sure that there's an actual ear canal, a meatus, because sometimes babies are born without that there. And so we would want to know that early on. And then we would also test their hearing, which babies usually recognize their mother's voice or their father's voice maybe. And so they kind of naturally turn to that side or to their mother's voice. But also they have now where they will look at the like the electrical impulses and the brain waves to make sure that the baby can hear, so that if they can't hear, you can diagnose it early on and figure out how to go about that. So after I look at the ears, I'm taking a look at the mouth again. I'm gonna make sure the tongue's moving freely, that there's no I cannot think of the word, but there is an abnormality where the baby's tongue, it has the attachment, or does not have the attachment, or does have the attachment to the bottom of the mouth where they can't move it freely, and that could cause issues with breastfeeding or being able to get the nourishment that this baby needs and swallowing and things like that. After that, I'm going to go ahead and take one more look at the face. The eyes I did look at earlier. I looked at the conjunctiva, the sclera, the pupil reactions and stuff like that. But here too, they would also bring an ophthalmoscope to make sure that this baby has the red reflex, make sure everything's looking good there in the back of the eye, and things like that. It's a little bit harder after they have that erythromycin ointment, but that is something that does need to get done. After that, I would go ahead and look at the neck. I'm going to turn the baby over, make sure there's no extra nuchal folds or any type of lumps, bumps. I'm going to make sure that it's freely moving, that there's no constriction, that the baby is able to turn for the most part freely. And of course you have to support their neck because they're tiny and they're new. I already did fill for the clavicle, but you would want to make sure that's also not causing any problems or anything like that. I'm going to take a look at here while the baby is breathing. I'm going to make sure that there's not a huge amount of accessory muscle use or grunting, because that's not a sign that's not a good sign. That means that the baby is working harder to get oxygen to its lungs, and that could also indicate further problems. So I'm going to make sure this baby's breathing unlabored, freely, and getting in a good amount of air. After I look at that, I'm also going to go ahead and take a look at the baby's chest, at the breasts. So I'm going to make sure that those are even. You would measure it in millimeters. You would make sure that the chest is not caved in, or that it doesn't have like a curvature, like a lump outwards. You want to make sure it's nice and even, and make sure that those abnormalities are not there. I'm going to also make sure that the baby's belly button looks nice and center where it's supposed to be. You know, not off to the side. For one, there should be an umbilicus, so if there's not, that would be an issue that you would have to take a further look at, but you want to make sure that it's there. Make sure there's no distension or anything like that. I'm going to go ahead and look at the genitalia now. So for a girl, a full-term baby would have the clitoris would be a lot smaller than the labia majora and minora, and that would indicate normal. But sometimes in premature babies, if they're born a little early, the baby girl's clitoris would be bigger than the labia majora and minora, so that kind of can tell you a little bit if they're born early. And for boys, you would want to inspect their scrotum. You want to look at the rugae that are there. You know, the more rugae that are there, the more full term the baby is, the smoother it is, the earlier they are. You want to make sure you're looking at their testes and feeling them here. Usually they're dropped down. If not, sometimes you can feel them. They're like little almond shape. And then you would also want to look at their penis, and you want to make sure that the you want to make sure that the tip and the urethra are where it's supposed to be, in the middle, not underneath the penis or on top of the penis. So you want to make sure that's nice and centered also in there. The last thing that you really want to look at here is the elimination pattern. So the way that you measure that is you just want to make sure that the first day the baby's born, you would get one diaper, which if they poop, they're going to have the meconium poop, which is like the sticky, tarry looking stuff, so they might have that the first couple times. If they're breastfeeding, you're going to have a nice golden yellow color. So the first day should be one diaper, the second day should be 2, the third day should be 3, and it goes on. So you just want to make sure that this baby is passing bowel movements. And overall, you just want to look for any type of rash. Look at the general appearance of the baby and make sure that everything looks nice and good. And let me take a look at my note cards and just make sure that I didn't forget anything. So we looked at skin color, hydration, texture, cyanosis, jaundice. Cry. The vernix. So the vernix, I did forget that. The vernix is like a cheesy coating that the babies have when they first come out of their mother. It looks like a cheesy white coating that they kind of have all over them. It's actually good for the baby. So you don't want to wipe all of that off. That's normal. You'll find it in their skin folds and things like that. And they'll be moist and hydrated. Conjunctiva, removal. I did forget to mention that in the genitalia, sometimes they may be bleeding. That is normal because of the mother's hormone changes. So there might be a little bit of blood when they first come out of the womb. But that is okay as long as it's not abnormal. It's not an excessive amount or anything like that. And other than that, I think that is everything. Of course, you want to always keep the baby warm, so we'd have blankets, plenty of blankets, make sure they're dry. Sometimes they get put in an incubator under some lights because if they have, jaundice or if they're a little bit yellow, they want to try and get that fixed as soon as possible. But the most important thing is to keep them warm because they are not quite at the point where they can thermoregulate themselves all that easily, and so that is incredibly important. So that concludes my newborn assessment.